But yeah, it's gonna be over just the upper extremity. So topics 5, 6, and 7. That's all it's gonna be over. Very similar to what you had last time, except, no math stuff. So hooray for that. So I believe it should just be multiple choice. So I think it's gonna be 50 multiple choice questions. The major focus on it is now really going to be all of your kind of anatomy and movement, and really how the muscles move, what they do, that kind of thing. So if you want to start focusing your studying, I would do it much more on, like I said, the anatomy, so muscles, bones, joints, and their movements. All right, any questions on any of that?
What topics will it be on again?
4, 5, and 6. Or I'm sorry, 5, 6, and 7. So yeah, just the upper extremity. All right, so today we are getting into the hip and pelvis here. So I believe you already covered this in lab. Now, remember that your hip is pretty analogous to the shoulder, but the main difference is that there's a lot more bony support with the hip. So unlike the shoulder, which is all soft tissue, the hip actually does have a true ball and socket joint. So you have that, the head of your femur really sticking into the acetabulum, where you actually have that bony support to it. And just remember that anytime you have extra support, extra stability, you're going to lack mobility. So your hip is, I don't even think arguably it is, your second most mobile joint you have. However, because you have that extra bony stability, you get less problems with, like, say, laxity in the hip. Even as much as you, say, use your hip every day, I mean, every step you take kind of thing, you don't get the same kind of breakdown with the hip that you would if you were using the shoulder in the same manner. Meaning that walking doesn't have the same effect as, say, throwing. Now, granted, if you're overusing it, it doesn't matter, what you're doing, you're still going to cause some sort of damage to it. It's just the hip was made for a lot more impact on it. Virtually all of the structures are the same. You have a labrum in your hip. The acetabulum or acetabular fossa is analogous to the glenoid fossa. Everything's just bigger. Now, one of the, problems with the hip is that it's one of your major sites of, say, developing osteoporosis. And it's all just because of the nature of how bone modeling works. Just like if you, say, scratch your arm, whatever, scratch anything on your body, you lose millions of dead skin cells, right? Well, every time you take a step, you create tons and tons of microfractures in all of your weight-bearing bones, which is good because it's essentially like getting that dead layer of skin off. You're kind of exfoliating it, and it allows then your body to reshape and remold your bone to make it perpetually stronger, kind of thing. It does this by a constant breakdown and buildup of bone tissue. So you know how in, say, chemistry, if you're doing just a typical like chemical reaction, something like, oh, my stoichiometry is going to be terrible, but whatever. You get something like this. I think that's right. Two H2 plus an O2, yeah, perfect. Well, what does that symbol represent?
Both sides can go both ways.
Yeah, you don't have a reaction going all one way. It's interchangeably going back and forth. This is exactly what happens with our bone tissue. Now, let's take our same basic chemical reaction. And what happens if you see something like this? What would this denote now? No. The side that has the longer arrow indicates that that's the side where the majority of the reaction is going. You get some backflow, but for the most part, it's going one way. Eventually, whatever your rate limiting step is or rate limiting ingredient is, that'll run out and the reaction will stop. If you have this happening in your bone tissue, this typically means that your bone breakdown is greater than the bone buildup. This results in a loss of bone density, which is, not a good thing. You want the buildup and breakdown to be about even. You also don't want the buildup to exceed either, because then you have, excessive bone growth, and that puts even more problems kind of on your plate there. So kind of what happens if you ever were to develop osteopenia or progress that into osteoporosis is you have that breakdown exceeding the buildup. The way that you get bone tissue to build up naturally is through impact or use, and also the appropriate minerals and micronutrients to help with the buildup of it. If you have osteopenia, you can reverse that, meaning you are currently breaking down more bone than you're building up, but it's still reversible. It's in the early stages yet. If you have osteoporosis, that is not reversible. So you hit a wall, and essentially once you cross that line to osteoporosis, you're kind of stuck with what you have. Whenever you lose bone density, it's essentially like you are kind of hollowing out a bone. So the way the bone looks under, like, say, a microscope is almost like I don't want to say like a honeycomb, but it's a similar kind of structure. And when you get, say, osteoporosis or osteopenia, you'll get, like, say, bigger gaps and spaces in between where, bone used to be, kind of thing. The less structural integrity you have, the less strength you have overall with the bone. Makes sense there. So the typically biggest thing that you'll see happen with something like this is getting a joint replacement So typically you would get a total hip replacement here, where the neck and ball of the, or neck and head of the femur would be cut off, and you'd have a surgical one or a surgical one. You'd have a metal hip put in place there. If, however, you had bone density breakdown going into, like, say, the shaft of your femur, if you drill anything into that, what will most likely happen is it'll just shatter that bone. So to correct something like osteoporosis, you need to do usually a joint replacement. However, if the osteoporosis is too advanced, you're going to just do more damage if you try to fix it, kind of thing. So it's not really a good thing to have. Now, usually I follow that up with, but it won't kill you. However, hip replacement surgery is actually your most dangerous orthopedic procedure you can have. You have approximately a 20% all-cause chance of mortality within 1 year post-op of a total hip replacement. And hip replacements, like any other joint replacement, are not permanent. You usually only get, depending on the use of it, anywhere from 10 to 20 years on that. So ideally, you'd want to get a hip replacement when you're older. That way you only have one. But if you have to get that fixed again, it becomes pretty difficult. I played baseball with a guy, I forget where he was from originally, but he's in Phoenix here now. Left-handed pitcher, signed with U of A, and in some freak accident he had when he was in high school, he stepped in like a hole in his backyard, like didn't see it, and broke his hip, like at 15, 16, something like that. Had to get a total hip replacement before, like, he could drive a car, kind of thing. So obviously that derailed a lot of his baseball career, because you don't hear of, like, say, teenagers getting a hip replacement kind of thing, which doesn't happen. But he ended up with a leg length discrepancy. So I believe his left leg is about a ½ inch longer than his right leg, which is not uncommon to see that. But he's going to have to probably have 2, maybe 3 revisions on that during his lifetime. So you can see how important, like, especially for that particular example, bone density is for sustained health. So with that in mind, our overall movements we have with the hip are going to be similar to the shoulder, but just a little bit less profound. Now, yeah, there's always going to be someone that's, like, say, a contortionist or, gymnast, whatever, that has awesome range of motion. But for the most part, even though you have a ton of a potentially available range of motion in the hip, it's limited by the massive muscles that are around it. So movements of the hip, pretty much same as the shoulder. So flexion, extension, abduction, adduction, medial, lateral, or internal and external rotation. Now, the other thing that you remember from lab is what happens when you sit down and you move your lower leg. So if I'm sitting, and I know you can all see me behind this nice fortress of chairs I have, what changes about rotation in the hip when you're in a seated position? Do what? Not really. It just changes the direction of the lower leg to describe the rotation of the hip. So if I'm seated in this 90-90 position, so 90 degrees of hip flexion, 90 degrees of knee flexion, and I move my lower leg outward, what direction is my hip moving?
Your hip's actually moving inward.
Yes. So if I put my lower leg outward or move my lower leg laterally, it is going to medially rotate my hip. And if you think about it, it's just kind of like what the hell's are those wrenches? Socket wrench kind of thing, where I turn one way to get the whatever screw, nut, bolt to twist the opposite way. And it's all just because you're at this 90-90 position. So then if I move my lower leg inward or my lower leg medially, it is going to laterally or externally rotate my hip. If I'm standing up even if I just have, full knee extension, then the rotation follows the movement of the whole leg. So if I turn my foot inward, I'm medially rotating. If I turn my foot outward, laterally rotating. It's only when I'm in this 90-90 position that if I move my lower leg inward, my hip rotates outward and vice versa. Kind of makes sense? I know I was never really all that great at, like, say, my visual spatial skills. So seeing it and being able to visualize it the visualizing bit was pretty difficult, but once you see it, it makes it a little bit easier to do that. All right, bones of the pelvis. What are those?
Ilium and pubic bone, and then the ischium.
Yeah, ilium, ischium, and pubis. For our purposes, the ilium's kind of the most important of the three. So the ilium is going, whoops, not that way. I don't want to go that way. I want to go the other way. There we go. So the ilium, and specifically the iliac crest, is going to be the most important thing for us in terms of landmarks. So especially this guy here, your ASIS or anterior superior iliac spine. That's a big marker we have. So your ilium, you would feel where you would, call your hip kind of roughly parallel with your belly button is where you're going to feel the ilium. And that's going to go all the way down. When you actually feel the side here by your pocket where your hip joint would be, that's actually going to be the neck of your femur. So it gives you an idea of just how kind of big that is. The ischium, you would feel if you sat down, it's right where your hamstrings meet your butt. That is where you're going to feel the ischium. And then for the pubis, really the best way to do it is I'm trying to think of a better way to say it other than it's right above where your private parts are, but I guess that's probably the easiest way to say it. But for all intents and purposes, the pubis and the ischium aren't all that important to us, just because the pelvis itself doesn't do much movement, and any of the landmarks we really need are pretty much exclusive to the ilium. Where to? Okay, wait. it's not telling me movements here. But anyway, your pelvis has 4 movements, but really only 3-ish are what we're going to be concerned with. So your pelvis does not flex, extend, or adduct. It tilts. Your marker or your landmark you want to be looking at is your iliac crest. It doesn't matter if you do ASIS, PSIS, whatever. AISIS, anterior inferior iliac spine. But your iliac spine is your landmark in relation to how your pelvis tilts. If your iliac spine moves forward, that is an anterior tilt. If it moves backward, it's a posterior tilt. If it moves up, it's a lateral tilt. So anterior tilt would be like if you pushed your hip forward or your pelvis forward, it would kind of give you more of a flat back. If I had a posterior tilt, sorry, I messed those up. Anterior tilt, I'm going to stick my belly out. Posterior tilt, I'm going to stick kind of my pelvis out. So anterior tilt gives me hyperlordosis or an excessive curvature in my lower spine or my lower back. And then a posterior tilt is going to give me more of a flat spine. You do have some rotation with the pelvis. It's not something you really even are going to be able to measure. So keep in mind that it does that, but I'm not so worried about that movement because it's not all that important for us. The other major issue you come up with the pelvis is if you have a Trendelenburg sign or Trendelenburg gait, meaning that you have a weak glute medius muscle, and it's going to create a hip drop on one side. And it isn't that, you know, say you're walking and you just see like your hips go kind of side to side like in a normal gait pattern would. It's, you would essentially be walking and kind of like a hip would give out almost kind of thing. So you have like one normal step of gait and then it would kind of give out. It's kind of hard to mimic that when you do have a functioning, you know, glute medius, but kind of like that would be what you would more or less see. And we'll talk more about that later. All right, versions. This here just describes how the hip is placed in its socket relative to the positioning of your lower extremity. This also is going to help explain why you essentially lose flexibility as you age. So if you remember back when you were small children, it kind of seemed that virtually any body position was achievable by you, mostly because you didn't have the muscle tone developed and your bones were a lot more skewed towards the cartilage side, meaning you had inherently much more range of motion than you would now. Specifically with the hip, what happens is that you'll see this here, this retroversion, where the hip itself will rotate posteriorly and it creates a wider angle you have between the femur and the foot or the femur and the leg. If you were, say, kneeling on both knees and then put your feet back, so like your top of your shoe is on the ground, you'd be able to get essentially into a W position. Most of you, I would imagine, can't do that anymore. I know I can't, and I'm going to try. But if you ever look at a small child and you ever see them, God, this sounds terrible, but on their knees, you'll notice that they will have their legs in a almost W position. And it's because they have this extra retroversion there. As your hip continues developing, you're going to start moving more towards an anteversion. So essentially, you are getting a decreased angle between the neck and head of the femur and your leg. Now, both of these that they show here are not really extreme examples, but it just gives you a very strict depiction of it. This is a natural process where things like this happen. The point is, though, that you want to end up here. The degree of version you have, or the angle that you have, is not really something you can change because you're talking about how your bones essentially set in place. The more anteversion you have, the really less stable your hip's going to be later in life. You'll actually have much more or a much greater chance of, say, like developing osteoarthritis in the area because you're going to have more direct impact on the hip. And if you ever see someone with anteversion, you'll see that they position, it's almost like their toes are pointed inward kind of thing. But if they were to, like, say, bend their knees, it would go straight. So it wouldn't be like, they were just turning their feet in just to stand that way. They would actually be in a, to them, anatomically comfortable position. Most people, you see some sort of retroversion where you have an externally rotated hip. It's not, anything that you're deviating away from normal isn't awesome. But if you had to pick one, having more retroversion would be better. And it's kind of like saying, would you rather have a rash or an ingrown toenail? But, if you had to pick one. Oh, and there it is. All right, don't worry so much about the angle of inclination. I'm not so worried about all that, but all this just does is it's going to really just dictate where that head of your femur sits in the acetabulum. All right, you have a labrum in the hip, same as you do with the shoulder, except you have a lot more vascularization of this. And it kind of makes sense because you have such high impact on the hip that you need to have much more support for that area. So not only is the labrum of your hip bigger and thicker, it also contains a lot more blood supply than, say, the labrum of your shoulder. And again, it's all because of weight-bearing status. If you were weight-bearing on your upper body, like if we were a quadruped-based species, you would have much more support in your shoulder. However, you most likely would have reduced range of motion in your shoulder. So it's kind of like if you ever have, a cat or a dog and you take their front limbs and try to raise them up, they have considerable resistance when you get, anywhere close to 90 degrees to them. And it's all because they have much more bony stability in those since they have to walk on those. All right, I'm not so concerned that you know all the ligaments for the yes, I'm not so concerned you know all the different ligaments here that go with the hip. Just know that the way that your kind of synovial capsule is made in the hip and kind of similar to the shoulder is it's almost like a mop. So like if you ever had like a mop you had to wring out, you twist the whatever strings, they turn over each other and they become tight and water all goes out. And that's the same thing that's happening here. You don't really have a straight set of ligaments. They all rotate around each other. And that's to create or allow from first off more range of motion, but also to add more stability to that. So it gives you more room to essentially move around while still maintaining as tight of a capsule as it can. All right, the SI joint or sacroiliac joint, while this isn't completely fused, it really doesn't move a whole heck of a lot. So it's good to know what it is, where it's located, the bones that it articulates with. But for the most part, your SI joint doesn't do a whole heck of a lot. So really its primary role is just to add an anchor point for really the spine. That's kind of about it. Now, the other thing too that I think many people visually struggle with is the actual location of, like, say, the sacrum. So remember, your sacrum's in your low back. So right where your gluteal cleft starts, like just above that is where the coccyx is. So your sacrum is really in your lower back here, which kind of makes sense when you think of the pelvis itself is up there as well. All right, so we talked about our tilts. Okay, we had the upper cross in our upper body. We were talking about the shoulder. You have a lower cross in your lower body in relation to the hip and the pelvis. For the most part, posterior tilts are rare. You're going to see posterior tilts the majority of the time while sitting. If you think of, like, say, yeah, I saw that. All right, so you, for example, would be showing a posterior tilt with how you're sitting. That is kind of the typical structure, what would happen to see a posterior tilt. With ambulation, most of the time you're going to be seeing anterior tilts. So the posterior one is usually more of a seated position, although it's not to say it's, you'll never see it, but for the most part, your gait pattern is going to showcase usually an anterior tilt, not a posterior tilt. And if you look, I mean, at why that is, it's pretty self-explanatory. Tight back, tight hip flexors, weak glutes, and hamstrings. hamstrings are also going to be tight, but that's going to be more distally and weak core muscles. So, pretty standard for the overwhelming majority of the American population, I'd say. And if you think about it, anytime you're walking, whenever you go into hip flexion, you're going to be tightening your hip flexors. Your lower back or your erector spinae muscles are primarily used for postural support. Well, if you're not using them, essentially, like if you're not keeping good posture, they're going to start kind of giving out or losing a lot of their actual like muscle tone. And with, like you say, and we'll talk about this more with the spine, but your erector spinae muscles are kind of like, almost like spaghetti strings in nature, meaning that they don't have the same kind of bulk to them that you would see with like many of your other bigger muscles. So irritating like one or many of them is very easy to do. But it's also something where these are not used all that much. I mean, if you think about it, how many of you are actively thinking about exercising your low back when you go and do like a resistance training workout? I mean, what exercises do you even do for that? Yeah. And maybe back hyperextension. Whereas if I'm going to go lift chest, what exercises can I do? Yeah, I mean, you can rattle off a million of them, right? Not quite something you're really thinking about is lower back. And I say that as a generalization, but it's not something that's specifically targeted. So it's very easy to imagine how that becomes weak. We use our hip flexors all throughout the day. So also conversely easy to imagine why those become tight. Now, for any of you that are exercising, working out, I mean, I'm sure you all have amazing core muscles, but if you think about the overwhelming majority of the population that doesn't do much exercise, very easy to see how core muscles are going to really degenerate on you, kind of thing. You gotta remember that your abdomen, like that's your bacon. Like that's what it looks like. Strip of bacon, that's straight from your abdomen right there. So lots of fat, little muscle tone, all that good stuff. Now, the weak glutes and hamstrings, the only reason why we have a protruding glute max muscle is because we're bipedal. You notice anything that walks on four legs does not have a butt, right? You look at any dog, you look at horses, you look at, I don't know, name any other four-legged creature. They do not have protruding glute muscles. It's also why they have very little need for, say, like toilet paper. And it's all because when you have four legs, you have much more evenly distributed balance among your muscles. When you have two legs, you have to have a much stronger glute muscle just because that's going to not only help keep you upright, but it's essentially completely responsible for your locomotion. So that's why glute max is your biggest muscle you have in your body, regardless of what your actual body composition is. But again, because you are using really glutes and hamstrings during walking, it usually tends to be underutilized in terms of strengthening. So by having these being weak, it doesn't mean like say you're debilitated. It just means that you aren't using them to where they would be most functional with it. So it's kind of like, I can guarantee that every single one of you can get up here and throw a baseball if you had to. But how many of you could throw a baseball with, accuracy and velocity, like high accuracy, high velocity? I mean, relatively speaking, probably none of us here. I mean, I might be able to break glass, maybe, but it's about it. So even though you're using it, I mean, any of you can, like I said, can use your arm to throw, but are you actively training it to become better at throwing? Now, again, if you are, say, not skipping leg day, then this really wouldn't apply to you so much. But for, again, everyone else that is, this is kind of generally what you're going to see happen here. And again, this is called your lower cross. All right, talked about tilts and rotation a little bit. Don't worry about this. Essentially, this is the little bit of movement you can get with the sacrum. The sacrum will move in really the kind of same direction as the ilium will, but that's really about it. Don't let the arrows confuse you, because this movement that you're seeing here is like 1 to 3 millimeters. So it's one of those things that, yes, it's interesting, but clinically it doesn't have any significance. Oops. All right, and probably should change that. All right, so if I do hip flexion, what's my plane of motion for this? And what's the axis of rotation? No. Medial lateral, yes. Sagittal plane, always medial lateral. If I do extension, same thing. If I do abduction, adduction, what's my plane? And what's the axis? There you go. And if I do my internal external rotation, what's my plane? Transverse. And then what's the axis? Longitudinal or vertical, yes, very good. All right, now, when you are looking at your norms here, like it says here, you're going to get some different sources on it. What you should know is that hip flexion is by far the greatest movement you have. Hip extension is typically going to be the least. And then adduction will be middle. Similar to what we were talking about with, say, like shoulder flexion turning into shoulder abduction, same thing happens with hip extension. So to get your true hip extension, you need to keep that back hip perfectly straight. Well, the whole reason why you have someone, like, say, laying on the table like they are, is to prevent this movement here. Because if I go and do a trunk flexion along with the hip extension, I'm really no longer extending the hip. So you want to really isolate the hip by immobilizing the trunk when you're actually measuring it. With the extension itself, if I kick back out and you see this outward rotation or this external rotation, that's what you'll see when people try to get too far of a range in extension. You're not going to be able to maintain actual hip extension if you go past that roughly 30-ish degree mark. You're going to start going into external rotation, which in turn means you're in abduction as well. Now, what is this an example of, this kind of movement? So remember, this is our passive insufficiency. Passive insufficiency means that a proximal muscle can't move or is too short, too tight if the distal joint remains in its end range of motion. So what this means here is that if my knee were fully extended and I were trying to just lift my full leg up, I would probably come nowhere close to 120 degrees of flexion. The only way you're going to get full range of motion in hip flexion is if you flex your knee. If you flex your knee, it's going to take off the strain from the distal hamstrings. All right, and there's your ab adduction. Why are all these done in a laying position, so either a supine or a prone position?
Probably balance purposes,
How so?
to prevent a compensation.
Kind of.
Close to anatomical position.
It is, but I mean, I can still be in anatomical position while standing. Kind of what you were saying there with the compensations is on the right track there. When you're in a gravity eliminated or a gravity assisted setup, you don't have a need for really the muscles surrounding the hip to be used for any kind of dynamic support. Meaning that when I'm standing up, inherently I have to tighten muscles on or around my hip to maintain my posture. If a muscle is tight, its mobility is going to be impacted. So you put someone in essentially a gravity eliminated plane or a supported position. It allows more essentially relaxation of those muscles to give you then full range of motion where needed. All right, now as far as muscles go, main hip flexor muscle is your iliopsoas. So remember that is made up of your iliacus and psoas major. They don't, I think, have it here. No, they don't have it here. But your quadratus lumborum, which would be posterior ilium, so your posterior superior iliac spine connecting onto your lower ribs and your lumbar spine. That's going to be responsible for your hip hike. So that'll help with it'll do somewhat of a lateral tilt for your hip. Okay. Anytime you have a muscle that crosses over a joint, it has to move that joint. So our main hip flexor is iliopsoas. However, all of my quads are going to assist with hip flexion. That is not their prime role though. The prime movement of both the, say, the hamstrings and the quads is at the knee. So quads are your main knee extensors. Hamstrings are your main knee flexors. However, because they both cross over the hip, they're both going to move the hip. Quads assist with hip flexion, hamstrings assist with hip extension. Sartorius is, I guess, somewhat important. Its only real notable thing is that it's the longest muscle you have in your body, but it'll assist with hip flexion and it does some assisting with hip adduction. Tensor fascia lata, this goes with glute medius. So TFL and glute medius are right on both sides of the femur. So if you feel for your femur, right on the side of your hip there, the front, immediately in front of that is TFL, immediately behind that is glute medius. So if you can feel where that neck of your femur is, put your hand around it, so you have one, like your fingers on the posterior side of it, thumb on the lateral side of it, and you abduct your hip, you'll feel that they both kind of work. If you go into more flexion with abduction, you're going to feel the front flex, and that is TFL. If I go into extension and abduction, you're going to feel glute medius contract there. So both TFL and glute medius are your primary hip abductors. However, because TFL goes in front of the hip, it is going to assist as well with hip flexion. For a bonus point, what cut of meat is your TFL? So if I went to my butcher and I ordered a TFL steak, what would they give me? So disappointing. Then again, you're college kids, so you may not know a good cut of meat, but that is going to be your tri-tip steak. I've been asking that question for 4 years now, and I still haven't gotten anyone to get that correct. One other thing to note with your hip flexors is that when you're, say, training, like say your core, and you're doing leg exercises to impact your core, mostly what you're training is your hip flexors. So let's say you're laying supine and you do like flutter kicks or whatever. Yeah, you'll get a little bit of activation in your abdominal muscles, but for the most part, you're activating hip flexors. So while it's not completely useless to do something like that, if your goal though is to train your core, you're really missing the mark if you're doing leg only exercises kind of thing. Now, if you're doing something like bicycle crunches or crossover crunches, those kinds of things, yeah, then the movement is going to be supplemented by an additional torso movement that's going to cause more activation of the core. But all in all, there's a lot better ways to get the core to work than doing like traditional crunches or things like that. It's also a lot of stuff that's much easier on your back as well. All right. Like I said, all of your quads and all of your hamstrings are going to affect the hip, but they only do it as really synergists. Your glutes are your prime extensors, your hip flexors or iliopsoas prime hip flexors. Quads are going to assist with hip flexion. Their primary role though is knee extension. you have your rectus femoris and then your three vasti muscles making up the quads. So vastus, medialis, intermedius, and lateralis. You can't palpate vastus intermedius. It's deep to rectus femoris. And when we talk about the knee, I think next week or something like that, we'll see that the way that you position, say like your lower leg, will impact how you can activate each of these quad muscles. All right, sartorius, again, this is going to help with hip flexion. It does a little bit with external rotation. It's also going to do hip adduction and assist with knee flexion. You know, that's great and all. It's not the most important thing to us. Anything on the medial leg is going to help you with some sort of adduction. Now, depending on where your insertion point is, will tell you if any of these muscles are going to internally or externally rotate the hip. So because pectineus is going to insert on the posterior lateral-ish end of the femur, it's going to externally rotate the hip. So it doesn't have anywhere to pull that hip internally. It can only move that externally. This is kind of analogous to your teres minor and subscapularis. I'm sorry, it's teres minor and infraspinatus. All right, another important thing with the TFL is that its tendon here, or the tendon that it helps to form, is your IT band. If you're having IT band pain, you're not going to see it in your leg. Well, your upper leg, I should say. It's going to occur at your knee. So anyone that has any kind of IT band pain, it's going to manifest itself at the knee. If you have, like, say, tightness or any kind of, like, say, knots in your muscle that's on the lateral thigh, that typically is going to be one of your quad muscles, not going to be your IT band itself. So IT band, you're going to look for symptoms at the knee, not in the upper leg. All right, so that's your main hip flexors. The extensors there, like I said, glutes are your main ones. So glute max is the hip extensor. Glute medius assists. Hamstrings assist. And this kind of gives you a better look at where TFL is versus where glute medius would be, which would be over here. So if this space is your hip, that gives you a better idea of where those relative movements are. All right, so glute max is going to be your primary hip external rotator and your primary extensor. All of your hamstrings, semimembranosus, semitendinosus, biceps femoris, those are all going to, again, assist with hip extension. Now, Biceps femoris does external rotation because it's coming on the lateral leg. Your semitendinosus, semimembranosus, are both going to do internal rotation. They're coming on the medial portion here of the leg. And again, those are much more important when we talk about the knee. So remember that they have a role with the hip. Both quads and hamstrings have a role with the hip, but primarily they're knee muscles. All right, glute medius is going to abduct, TFL is going to do that as well. So again, here is where that hip bone is. TFL is going to be here. Both will do abduction. Now, here's the one thing about glute medius that makes it more of a jack of all trades, is that you can have it rotate the hip both directions. And this really just has to do with its positioning here. It's positioned, or its insertion point, I should say, is really medial posterior on the greater trochanter here of the femur. However, the origin point goes really the entire length of the iliac spine here, or the iliac crest, I should say. So this means it has access essentially to the anterior and the posterior side of the femur, allowing it to then rotate both directions. All right, glute minimus, don't really worry so much about that. The internal external rotators, remember glute max is going to be your major external rotator. Glute medius is going to be internal. Anything that says adductor on it does, surprise, surprise, hip adduction. Okay. Let's see here, a couple of other things here. When we say want to do any kind of testing on the really flexibility of your lower leg, you're going to use that whole passive insufficiency principle as a main measure of how you would do it. So if I do something like, say, your Thomas test or your Kendall test or your modified Thomas test, you're going to do that all to really kind of quantify flexibility. God, I really hope I don't kill myself here. All right, so if I'm doing, say, my Thomas test, what I would do is I have my legs hanging over here, and I'm going to raise up my leg, and you can already see it happening there, I'm sure. See how my other leg raises up? That suggests that I have tightness in the bottom leg or the flat leg. This should stay perfectly, bent like this, but as I bring this up, that's about all I can get before I can feel it start moving. So doing things like that are how you quantify flexibility there, other than, actually measuring range of motion. If you have a positive test on that, then it's going to obviously suggest that you have tightness in that area. And we'll revisit that again next week here. Now, one of the things I wanted to kind of finish up with here is our kind of kinematic analyses. I haven't seen it so much out of this class, but historically, when classes are asked to, say, kinematically analyze whatever movement for this body part or this area, they don't tend to stay there. The one I think of would be like, say, the volleyball serve. I know that's a question somewhere we did. And what's happening at, say, like the shoulder? And I'll get people answering, well, this is what's happening at the elbow and the forearm and all that good stuff. Well, that's great, that does happen, but it's not the shoulder. So whenever you're kinematically analyzing something, make sure that you're sticking to the parameters set from like the question. So for here, if we want to kinematically analyze what's going on here in relation to the hip, what would you say is going on? And let's just do the guy with no shirt. So what is happening at his hip?
Hip flexion.
Where?
And his left leg.
All right. And what else?
Extension in his right leg.
Kind of. I mean, I guess I'll give that to you. More or less in a neutral position there, but yeah, I'll give you that. All right, so on the left side of his body, what muscles are doing what? That's right.
All of his quads are helping there too.
Yep. So what kind of mover is iliopsoas?
Prime.
And what are your quads?
Center.
And what are my antagonists?
Your buns.
And
Your hammies.
yes. And then what are my stabilizer muscles?
The core.
The what?
Core.
Yeah. Remember, a stabilizer does not act on the joint of movement. It stabilizes the surrounding joints so that the target joint can move easier. All right, now on the right side, what's happening? What muscles are moving?
His hip extensions, glute max,
And,
spine, mechanosis, tendinosis,
and,
and the biceps femoris.
there we go. So hamstrings and glute max. Which one's my agonist? Which one's my synergist?
Glute max is the agonist.
Yep,
With the hammies as the synergist.
yes. And then what would be an antagonist to this?
Your hip flexors.
Yes. When you're doing any, like, so they appear to be doing like maybe an A march here, something like that. When you look at, like, say, the concept of like speed, agility, quickness, and even like say into plyometric training as well, you use your stretch shortening cycle to help improve really your explosive based movements for stuff like this. What's happening is that you get a kind of pre-stretch out of this, and then a powerful eccentric contraction, which you then use to develop your concentric contraction. What that essentially looks like here is that your pre-stretch for our guy without the shirt here, so he flexes his hip, flexes his hip. His hip flexors are working. His glutes are going to be contracted because they're antagonistic. Well, they're going to be, I should say, stretched because they're antagonistic. They're going to have opposed prime mover. When that leg goes back down, you're going to see an eccentric contraction occur with your hamstrings and your glutes that then sets up a powerful concentric contraction from both the hamstrings and glutes to then propel you forward. This is how you're able to generate and continually generate a lot of power, because you constantly are essentially pre-priming that muscle to fire and then having it fire. It's kind of like if I told you to brace for impact rather than say nothing and just let you take it, kind of thing. If you know some sort of outside force is coming, you're going to essentially tense up. If you don't, you won't. You'll be more relaxed. Well, that tensing up is going to help improve whatever. Let's say someone's going to push you. Well, if you know someone's going to push you and you can essentially set yourself and get ready for it, you now have a better base of support. You're increasing your inertia, all that good stuff. If you didn't know someone was going to push you and they did, more likely than not, you're going to stumble and or fall over. That's because you don't have any time to essentially set yourself up. This is all why you would do this really stretch shortening cycle when doing explosive based movements. You get that pre-stretch and the eccentric contraction in as a way to prepare for the force that you're about to then exert. So you prime your muscles before they're actually used. By priming them, you essentially can load more really force to them, kind of thing. If that kind of makes somewhat of sense. I know that's more of, I guess that'd be X-Phys in this. All right, this here. Let's look at the guy just because he's in the foreground. And this is right, this is left. So what is happening with his right hip here? Yeah, right hip is flexed, pretty standard there. How about his left hip?
Abducted.
Not abducted.
It's externally rotated.
It's externally rotated, yeah. So he's in slight flexion there. But again, look at the positioning we have with the legs. 90 degrees of, well, roughly 90 degrees of knee flexion, roughly 90 degrees of hip flexion. He's moving his left leg under his right leg. That's going to create external rotation of the hip. What muscles are acting on the left leg? So what's my prime mover here?
Gluteus.
No. Glute max, yes. Hamstrings are a prime knee flexor, but they're only going to assist with our hip extension. Glute max is our primary external rotator for the hip. And then what is my synergist?
Is it the glute medius?
There you go.
Okay. So I was like, oh.
So yeah, glute medius is going to be a synergist for that. What will be an antagonist to that? Minimus, yeah. What else? That's kind of an exception to the rule. Because it itself can do both motions and there's no fiber separation, it doesn't essentially antagonize itself. But it's still a good thought though. Because you can argue, for example, like say anterior deltoid is an antagonist to posterior deltoid because the fibers are separate essentially. But they're not separate for glute medius. So any of your deep internal rotators are going to be there. I know we kind of just breezed over these. So glute minimus and then hamstrings. Oh, here we go. All right, now let's look at her. Yeah, that's left. All right, what's happening at her left leg here?
External rotating.
And
Flexion.
no. Yes. I can see how you could potentially argue flexion, but it's the easiest way to counter that is with her foot positioning. You wouldn't see the complete side of the foot if she were in flexion. It would be slightly obscured, essentially. And the fact you can see the whole side of her leg kind of points to that. But anyways, yeah. So she is abducting her leg and externally rotating it. Now, she has clearly much better trunk stability than I do, because if I do that, I have to turn, whereas she is perpendicular there. God, that does not feel good at all. Did any of you ever do like point ballet? I don't want to stereotype by just staring at you three, but my sister did that, and like I feel like it's a medical miracle that anyone can walk after doing that. Even though I realize the shoes are padded and whatnot, but gosh, that cannot feel good. Anyways, so we have external rotation and abduction. What are my agonists here?
The glute max.
And huh?
Gluteus medius.
Yes, glute max and medius. You have two movements here, so you have two agonists. So for the abduction, glute medius. For external rotation, glute max. What would be my synergists here? All right, for what? Okay. What else?
External rotation of piriformis.
Piriformis would work. Glute medius will also be a synergist for the external rotation part of it. And then what would be my antagonists?
Adductor muscles.
Yeah, any of your adductors. And what else?
Or internal rotators.
Yeah. So primarily glute minimus would be there. All right, don't worry about your gait forces right now because that's going to be its own whole section. But just so you know that when you are doing any kind of like walking, running, you're putting more than your body weight on your body. Or I guess a better way to put it is that you don't have your body weight evenly distributed. Meaning that if I'm on one leg, like in any walking motion, my entire body weight goes on this one leg because this one has no weight bearing status right now. So this is where it gets to this idea of peak forces on the joints. Now, if I just stand on one leg, theoretically, I have now roughly 2 times the normal or my normal carrying force on the one leg than I would the other. If I have both feet down, I have 1x amount of weight that I'm holding. So typically like half your body weight would be on each leg, you know, theoretically. If I'm on one leg, whole body weight on there. Now, when you step and you land specifically, you're landing with more force than what your body weight is because you have a force you're generating from the movement. So this is where you get into these multipliers. The bigger the impact you have, the more force that's going to be on the joint. So meaning if you are running fast, if you're jumping, you're going to put greater impact on your joints than if you're, say, walking. Now, things that are going to artificially increase joint forces or joint impact force are going to be the surface that you're walking on or you're ambulating on. Something like carpet is going to be much more absorptive of a force than, say, concrete. Grass is going to be better than, say, carpet. Most tracks, I don't know, I really haven't ran on ours. I haven't done much running, period. But usually tracks now are kind of spongy almost. It's like I think like they use like a crumb rubber kind of thing to make them. All of that is just to have better absorption of the force. The worst thing you could really do for yourself in terms of like lower extremity joint health is run on a treadmill. It's actually one of the worst things you can do. For all of you potential CSCS fans out there, a test question that you would see on that is what incline would you raise a treadmill to reduce the impact you had on your lower extremity? And the answer to there is 2 to 2.5% incline. Any idea why that would reduce your impact? And if you are treadmill fans, try doing a walk run on flat ground and then a walk or run on, like I said, 2.5% incline. And you'll notice there's very little noticeable difference in the difficulty of it. It all has to do with what's actually hitting the belt. So if I'm flat and I run, primarily I'm hitting the heel on the ground. Well, your heel has very little surface area. If I raise that incline up just slightly, now I land more flat-footed. The more flat-footed I can land, the more energy dispersion I have. Because remember, Newton's third law says what? Third law of motion. Well, this really bums me out.
Equal opposite reaction.
There we go. So if I am hitting my heel on the ground, very little surface area, whatever force I hit, that ground is pushing it back on me. Well, when it's concentrated on a small area, much heavier impact. It's kind of like the whole, stepping on a nail versus laying on a bed of nails kind of thing. More flat-footed I land, the more dispersion I have, bigger surface area. Treadmills by themselves are bad because they're narrow and they have very little ability to disperse that energy you create. Even if you do, like, say, concrete outside, much greater surface area to land, much easier energy dispersion. But yeah, typically like grass is usually your best bet for like running if you wanted to do that. But anyways, 3 is the magic number here. So if you have 3 or more times your body weight of force impact, it's going to lead to degeneration of your lower extremity joints, which you don't really want to. And really, if you're trying to do like some sort of cardio-based exercise, running isn't, even in the most, is it efficacious or efficacious? But it doesn't have the greatest amount of efficacy anyway. So if you ever look at the risk-reward continuum for exercise, it would be really not the dangerous zone, but it wouldn't be ideal. It'd be kind of like that caution zone. All right, and don't worry so much about this right now, but this is just how you're really calculating really force from the hip and knee relative to the amount of femoral version you have. But like I said, don't worry so much about that. All right. What kind of questions do you have on the hip? All right, so remember our hip has 3 degrees of freedom. It is a ball and socket joint. The actual joint name is the acetabular femoral joint. I probably should have said that. But you have flexion, extension, abduction, internal external rotation. Remember how internal external rotation changes when you are in a 90-90 position, meaning 90 degrees of hip flexion, 90 degrees of knee flexion. The bones are the 3 pelvic bones, but really you only need to know the ilium. And then your femur. Major muscles to remember, your 3 glute muscles, so medius, maximus, minimus. Your hamstrings, so biceps femoris, semimembranosus, semitendinosus. Your hip flexor, or your main hip flexor, iliopsoas. Your quads, so vastus lateralis, medialis, intermedius, rectus femoris. Your adductor muscles. All your adductor muscles are named adductor. Abductors, primarily glute medius and TFL. A little bit from sartorius, I guess. But yeah, that's about it. I mean, if you really break it down into these fundamental pieces, it's not really all that complex. At least I like to think so. All right, well, if you all don't have any more questions, then you guys are all good to go. So thank you all for getting through all this with me. So I'll let you out a couple minutes early here. And then, like I said, next week we will review for your second exam, and then we will be moving on to the knee as well.